we will another topic of mine today to talk is on navigating the complexity in the management of babies with congenital hyperinsulinism. No disclosures. We'll go through the diagnosis, utility of diagnostic tests, medical treatment, genetics of congenital hyperinsulinism, imaging, and the complexity of surgical treatment. So congenital hyperinsulinism is a rare monogenic disease where the hallmark is inappropriately increased insulin secretion. It is a devastating disorder due to deprivation of glucose and ketones to the neurons. Recurrent and severe hypoglycemia can cause brain injury, leading to neurodevelopmental delay. So normally when you think about hyperinsulinemia, hypoglycemia, there are three outcomes. One is spontaneous resolution. Next is cure after a diagnosis, genetic testing, imaging, surgery, the cure. And the other one is a disaster where we didn't screen adequately and the baby go home with subclinical hypoglycemia, which persisted and caused brain injury and even death. So before we start with that, let us see the normal insulin secretion mechanism in the beta cell. So this is a pancreas with a beta cell, which is the key structure is the potassium ATP channel, which is composed of two channels, that is sulfonylurea receptor and the potassium inverter rectifier. And it is regulated by ABCC8 gene and KCNJ11 gene in the 11th chromosome. At the resting state means the beta cell is not challenged by glucose, the channel remains comfortably open. But when the glucose comes into the cell, the channel closes. So let us see what happens when the glucose comes in. The glucose enters the cell. By the glucotransporters move the glucose into the beta cell. It is acted upon by glucokinase, resulting in production of excess amount of ATP, or in other words, ATP to ADP ratio increases. This is the stimulus for the channel to close, which was remaining open all this time. This leads to depolarization of the cell, which causes influx of calcium into the cell and release of insulin from the stored vesicles. So the point we need to keep it in mind is the potassium ATP channel, the key structure with the two channels, which is regulated by two different genes, and they remain open during the resting state and closed during the activity of the glucose inside the cell. So a diagnosis of HH is made after 48 hours of life when a baby requires a glucose infusion rate of more than 10 milligrams per kg per minute. The diagnosis comes to our mind and we do the critical bloods. We find that insulin is detectable even when baby is hypoglycemic. As I mentioned before, that less than 3.5 millimoles per liter of glucose in our blood is a point at which the insulin secretion stops. But here you can see that even at levels below 3 millimoles, the insulin is detectable. And low ketones and low fatty acids supports the presence of insulin. Glycemic response to glucagon, by giving one dose of glucagon IM, normally we should get a raise of glucose by 1.7 millimoles per liter, but in hyperinsulinism it doesn't happen. So that will conform. In addition to that, we can do cortisol and growth hormone to see the counter-regulatory hormone response. We have three forms of hyperinsulinism we are talking about. One is the transitional form, which lasts for 24 to 36 hours. Perinatal stress hyperinsulinism, which lasts for 3 to 6 months. And congenital hyperinsulinism, which is a persistent form, depends on what treatment you are giving. The resolution or the treatment, the cure takes its own time. Now we are going to look at something interesting. We are looking at the sensitivity and specificity of various tests we do to confirm hyperinsulinism. The number one is insulin is inappropriately detectable in all cases of hyperinsulinism. This is why we always have this rule in our mind. But do you know that this is published by Diva de Leon from CHOPS in clinics, best practices in research, clinical endocrinology and metabolism. You can see that the insulin levels are plotted in the y-axis and the glucose levels are in the x-axis. And you can see all these red dots are all red squares are HI patients and the controls are shown as circles. And we can see that even at glucose levels below this, the insulin remains low. So how do you diagnose then hyperinsulinism? If the insulin remains low, but actually the patient has got hyperinsulinism because ketones and glucose are low. There is not many conditions where you can get ketones and glucose low at the same time. So the explanation for this is it HH when insulin not detectable during a hypoglycemia? When glucose is low, ketone is low, fatty acids are low, and the glucagon stimulation test is satisfies the criteria. That means the glucose didn't go above 1.7 millimoles. The explanation is the absence of insulin in HH is due to anti-insulin antibodies which has come from the mother, which neutralizes the insulin in the baby circulation. Second explanation is if the sample is hemolyzed due to the difficult sampling, the insulin degrading enzymes from the RBC will destroy the insulin. So these two are the explanation for if insulin is normal response, means no insulin detectable, but glucose is low, ketones are low, fatty acids are low, glucagon stimulation test is positive. And with normal cortisol and growth hormone, you are challenged at this point to make a diagnosis of hyperinsulinism. So the focus should be on markers of insulin action, not on insulin level. This is what Professor Charles Stanley gives this comment in one of his recent papers in 2023. So the sensitivity of this test is about 82%. So C-peptide in the diagnosis of hyperinsulinism, C-peptide estimation is unaffected by hemolysis. So C-peptide will be still detectable. Do you know that why we do C-peptide? Because it's an endogenous insulin, showing the presence of endogenous insulin. Whereas when you do the insulin levels, it can be exogenous. You know the Munchausen by proxy is nurse who injected insulin into the baby to kill the baby. So the injected insulin we can detect, but the C-peptide, if it is present, we can definitely say is endogenous insulin, but insulin alone will not help. So for litigation purpose, we may have to do C-peptide in the countries that worries there. Here we don't do it in Singapore. So you can see that C-peptide levels are suppressed, are detectable in hypoglycemia, irrespective of the fact that the insulin levels are not detectable. Because insulin could have been destroyed by the thing, but by hemolysis, the RBC enzymes. But C-peptide will not be disturbed. So 100% sensitivity if the levels are above 0.6 nanograms per ml. So C-peptide level, if you can get this much, is 100% sensitive. Assay dependent, variable, depending on the lab what they use, and longer half-life. Sensitivity is about 88.5% in general, but if it is below 0.5. Ketones are the most sensitive one, which is sensitivity is 100%. You can see the insulin, the ketones are low when the baby is having hypoglycemia. So the focus should be on markers of insulin like ketones, not on insulin levels. Again, free fatty acid is same story. Free fatty acids will be undetectable or low levels when the baby is having hypoglycemia with no detectable insulin can still be hyperinsulinism. IGF, insulin-like growth factor binding protein 1, it will be low during hypoglycemia and hyperinsulinism. Not bad, it has got a sensitivity of 85% if the level is below 110 nanograms per ml. So this also is another sensitive test we can do it. Glucagon stimulated rise in glucose. I told you already, 1 milligram of glucagon, if you give it an 88.9% sensitivity for this test, if the glucose levels doesn't go above 1.7 millimoles per liter within 30 minutes. Interestingly, Professor Charles Stanley's recent article in 2023 says we can predict whether HH is going to be transitional, prolonged, or persistent. Look at the GLOW study. What did they find in GLOW study? They looked at the glucose and ketones, advocating screening both glucose and ketones for all these high-risk babies. How does it help us? We can see that the glucose levels drops initially, but the ketone still remains low immediately after birth. By 20 hours, we can see the ketone levels start rising and coming up along with the glucose levels and helps them to tide over the situation by 60 to 80 hours. But after that, they come down to low levels and the ketone remains low in fasting. So what does it tell you is that now who helps the babies if the glucose level goes down? We told already first 1 hour the glucose levels can go down as low as 1.4 millimoles. So along with this, the study team from New Zealand, they did also the lactate level. You can see that beautifully the first few hours, the lactate gives us a substrate. Lactate functions as a substrate to produce glucose. So that is how the babies maintain the third best substrate available. And you can see once the lactate level comes down, you can see beautifully the ketones goes up. You can see the ketones go up and they come down by about 80 to 100 hours of life. So this is how there is. So what we notice is that the conclusion from this study was that if this ketone levels doesn't come up and it remains consistently low, we can say that this baby is going for a prolonged HH. So hypoketonemia, if it persists beyond 48 hours, we can take it for granted that the prolonged HH is coming. It can be either perinatal stress-induced hyperinsulinism or it can be congenital hyperinsulinism. So if hypoglycemia along with hypoketonemia persists beyond 48 hours, we should consider one of these causes in these babies. Normally, it should have resolved within 36 to 48 hours. You can see that beautifully they resolve and they start climbing up to even 80 milligram per kg, 80 milligrams of glucose per 100 ml. So this is an interesting study which is published recently and looking at it. Now the question is when to decision to treat. So this is the one I always stress on, that to delay the treatment of diazoxide because of the spontaneous resolution chances are there. We know that infant diabetic mothers, they can resolve within 5 to 7 days. So no justification to give diazoxide to these babies. Term SGA babies in 10 to 14 days and preterm SGA babies in 14 to 21 days. This is what we studied. We looked at the watchful waiting versus pharmacological treatment. In these babies, we looked at 3 parameters: central line duration, length of stay, and total intervention days. When you give diazoxide, there is not much change between central line duration and length of stay. But what is the significant difference is the total duration of treatment, because diazoxide babies are going home on diazoxide, then they remain monitored, followed up, and a resolution fasting study. So total duration of treatment of theirs goes very 64 days, whereas the watchful waiting group, the mean is about 70 days. So statistically, it is significant. So justified in delaying the treatment of diazoxide if possible. As I told before, the diazoxide is a harmful drug because it blocks the potassium ATP channel. Just now we saw the potassium ATP channel, how important it is. And if you suspend or put the channel in the opening state, inhibiting the insulin release, you are going to give harm to other parts of the bodies. The suspension is expensive and the capsules and tablets are not cheap, but they are not effective because both are insoluble in water. While initiating diazoxide, you need to delay the treatment. Safety profile, you need to check in the liver function and the renal function. So you must know when to start and how to start. To prepare the baby for with a blood count, full blood count, because neutropenia can occur, thrombocytopenia can occur, especially in SGA babies. Dose I suggest is 80 AGs and LGs. We can start with 5 milligrams and go up in increments of 2.5 milligrams up to 15 milligram per kg per day in 2 divided doses. SGs, you can start with 2.5 to 3 milligram per kg per day. We have already published this, the low dose diazoxide safety and efficacy in Archives of Disease of Childhood, Fetal and Neonatal edition in 2022. Thiazides reduce their water retention, and so that is one side effect which can be controlled by using thiazide diuretics along with diazoxide. Hypertrichosis, but it's self-limiting. Neutropenia and thrombocytopenia, again, need to keep an eye on that by monitoring them. Echo before diazoxide initiated and after 2 weeks to look for any presence of pulmonary hypertension appearing as a new finding after starting diazoxide. Fasting studies are very important. The safety fasting study decides on whether the baby is sufficient dose to avoid an inadvertent fast at home, because the mommy may sleep off in the night and may allow a fast for 6 hours before they go home. If they fail, we have to increase the dose by 50% and allow them to stay in the hospital for 2 more days to get a good glucose readings and then repeat the fasting study. So with a pass in the fasting study, safety fasting study, they go home. Then stop the medication when the dose drops to 50%, because we allow the drug to self-wean with the weight gain. When the weight reaches more than double, we know the dose has come down by 50%. And after that, we can stop the medication, allow the baby to remain at home with continuous glucose monitoring and while on feeds, and then admit the baby on day 4 to the hospital for an age-appropriate fasting study to confirm the resolution of hyperinsulinism. Now comes the disoxide unresponsive group. 60 to 70% of these babies have got a problem in the ABCC8 and KCNJ11 gene. Once this gene is mutated, the channel remains persistently closed, leading to persistent depolarization, influx of calcium, and continuous release of insulin. So when you check the blood glucose is low, but you will find insulin irrespective of the fact that the glucose is low, ketones is low. Disoxide unresponsive requires high JR to maintain the euglycemia during this period. We can start with the glucagon infusion temporarily to tide over the situation while we are sent for sample for genetic testing to the concerned lab. The results will be available within 7 to 10 days, and some labs may take 10 to 14 days. The glucagon infusion, we can start and gradually increase it to maintain glucose levels, but it can produce serious side effects like necrolytic migratory erythema, as shown in this picture, which could be worrisome, but we can stop glucagon and move to the second drug, that is octreotide. The percentage of these babies do respond to octreotide because they got multiple sites action. They can block the calcium influx, as well as it can act on the safranin receptors. Genetic test results will indicate either known genes, like 16 genes have been known, of which ABCC and KCNJ occupies about 60 to 70% of the cases. Rest often we will find GCK and GLUT1. We find more HNF1 alpha and 4 alpha mutations in this part of the world, that is in the Asia. And but the problem comes is variants of uncertain significance. We may get a mutation in ABCC8 which is not yet reported. Whether that mutation has caused the disease is a question. We may have biochemical evidence. We have we have imaging evidence. We have we have got histopathological evidence of the post-operative samples, but we cannot say whether this gene has produced the disease. This particular mutation has caused the disease. So VUS is a rare or novel variant for which the disease pathogenicity has not been conclusively demonstrated or excluded. Rapid next-generation sequencing has uncovered a multitude of VUS. Pathogenicity of VUS can be established by a combination of analyzing the population data. Ideal is to do functional studies or review the literature and databases to look for the variance impact on health. And if more than 3 cases have been published with the same variant of uncertain significance, it will be established as a causative agent for the disease. So we started a functional studies in 2023. We joined with the Institute of Molecular Cell Biology, A-Star Singh Health. And what we do is, we recruit individuals with genetic forms of HH having VUS, obtain the human tissue and stain them for proteins of interest to help determine the mechanism of action. From the blood, this is the most important step. From the blood of the patient and the parents, we make human-induced pluripotent stem cells and differentiate them into pancreatic beta cells for mechanistic studies. In these cells, we can study the genes and proteins to determine how the mutation has affected the protein localization, affected channel function, signaling, and hence the mechanism of action. So this is the only way to prove that this particular mutation has caused the disease in this particular patient. So the gene library will accept it as a causative or a pathogenic agent for or a pathogenic certificate for this mutant, this particular mutation, only if we prove it by a functional study. Otherwise, we have to wait probably for how many years, I don't know. We have to get 3 people have to report the same variant has produced disease in 3 cases by histopathology, biochemical and imaging. So now the question comes about the diffuse and the focal forms. The histological forms, we get it when we take out the samples and analyze them. The focal forms are very commonly paternally inherited potassium ATP channel recessive variants. Paternal isodisomy in chromosome 11p15 with loss of maternal allele. So diffuse forms are all beta cells are affected, and biallelic variants and single heterozygous variants are causing it, both dominant and recessive forms. Our experience, which is unpublished but in the paper soon, we have 5 cases of paternally inherited congenital hyperinsulinism in the recent past. 2 were known pathogenic and 3 were variant of uncertain significance. But interestingly, all these 5 cases, the genetics report came as focal disease. So we have to go for DOPA-PET imaging. And with imaging and excision biopsy, we have showed that all the 4 cases, out of these 5, 4 cases were diffuse forms, and only 1 baby had a focal lesion in the tail of the pancreas. So coming to the imaging of the congenital hyperinsulinism, this is another task for the physicians dealing with congenital hyperinsulinism, because these scanning facilities are scarce, availability is very scarce because the cost of it, the manpower required, and the availability of the DOPA tracer. So the ideal or the gold standard is 18F DOPA PET CT scan, but now there's an alternative one which is called extended scan. Next slide, please. So as I said, DOPA PET CT scan is the ideal one, the gold standard for imaging congenital. The accuracy is about 85 to 89% in identifying focal forms. The challenges are the scarcity of this imaging modality, expensive. In UAE, it will cost you about 10,000 UAE dirhams, whereas in Singapore, it costs about 4,000 Singapore dollars. Need for expertise to prepare the tracer. Shorter half-life means if you prepare the tracer, you need to use it within 110 minutes. In case if there's a delay, this cannot be used. Challenges in interpretation of the images. So usually centers do share their images with other centers and get a consensus on the diagnosis. You can see from the image on the right-hand side, the activated lesion, you can see that there are 3 red knots, 3 red marks you can see there, of which the 2 on the side of the vertebral column are the kidneys which are excreting the same contrast, but you are seeing one on the middle is a typical focal lesion seen on the body of the pancreas. Thank you. Extended scan has come in the recent past. The advantage is you don't need a technical person to prepare that. It is a ready-made thing and it can be used immediately. No good studies show the superiority of DOPA-PET scan over extended scan. But somebody like Boss et al. Published a paper showing 19 infants between the age of 4 to 22 months who had DOPA-PET and extended scan. And the only study available with a small number of infants, and they concluded that extended force scan has got a highest clinical sensitivity of 100% compared to 71% and better inter-observer correlation than FDOPA. But we have used an extended scan, but limited experience. With whatever limited experience, we can comment that extended scan is not the ideal one for infants. For older children with nesidioblastosis, it's an ideal scan tool. So still, I have spoken to the experts in the world and they all agree that F-DOPA PET CT scan is the ideal one for using in neonates and infants with congenital hyperinsulinism. Next slide, please. Now coming to pancreatectomy, you know that the surgeon needs an extremely good skill to do that laparoscopically. But do you know the size of the human pancreas? In the newborn infant, the pancreas weighs only 4 grams. So his expertise comes in that, especially the real challenge is when you have got a focal lesion in the head of the pancreas, and which is sitting in a very risky area because of the C lobe of the duodenum with the superior pancreaticoduodenal artery, inferior pancreaticoduodenal artery, the proximity of the superior mesenteric artery and the superior mesenteric vein, and the bile duct. So the precision surgery depends upon the expertise of the surgeon. Focal we have to do always better to do laparoscopic excision because it is the easier one with less scar and easy early discharge from the hospital is the higher priority. Challenging the focal lesions of the head of the challenge is the always the focal lesion of the head of the pancreas using laparoscope. Anatomical proximity of all these major things makes you really challenging to do this lesionectomy in the head of the pancreas. But experts' opinion is that always do open resections because you will remove less pancreas if you do an open resection because you can see it on and also you can do the frozen section by the pathologist and we can correctly take out the right amount of tissue. So this is what the recent one publication in Journal of Pediatric Surgery where they done 500 cases where they showed that open sections are much better than the laparoscopic lesion. Diffuse lesions, we usually go for subtotal in the past, but currently the trend is to go for 95 to 98% because of the recurrence and then going in for a second time. Even we have gone in the last 10 years 2 times to repeat the surgery. Laparoscopic excision reduces the hospital stay and hastens the healing. Next slide, please. So the postoperatively, not a big issues. Hypoglycemia occurs in 50% of the cases, which requires medications and nocturnal feeds. And usually it resolves after maybe a few weeks. Hyperglycemia occurs, we can immediately manage with insulin. And euglycemia occurs in 30% of the cases. All our cases who had hypoglycemia, we have waited for some time. Some babies might require some medications for some time. So we may start back on octreotide or some even require glucagon with sub-Q infusions. The long-term follow-up for diabetes and pancreatic insufficiency is a must because we don't know when they will develop, but usually it is considered that after subtotal or near total pancreatectomy, they develop within 15 years. Our earliest one we had was a child at 12 years of age after neonatal pancreatectomy, diffuse lesions. So in summary, we have diagnostic challenges. As I told you, insulin may not be detectable, but with low ketones and low glucose, we must consider the diagnosis of hyperinsulinism. Medical treatment, always delay because there is a possibility of spontaneous resolution. Genetic testing may misguide you because of the variant of uncertain significance, but we may have to do continue with the imaging and surgery and confirmation by pathology. But remember, the confirmation, even though done, but we don't know whether the pathogenicity of this particular genetic mutation. Imaging is a must, and we need to rule out a focal lesion always before we go ahead with pancreatectomy. Surgery is the only solution for babies having focal and diffuse lesions. And subtotal and near total pancreatectomy have been practiced, but prefer to use near total pancreatectomy, that is 95 to 97%. Lifelong follow-up is required for these patients. Next slide, please. Thank you very much.
Thank you. I think that was fascinating again, and I'll stop sharing now. Okay. Regarding the free fatty acid, do you get the results fairly quickly?
Free fatty acids, we know that the fatty acids break down and releases the long-chain fatty acids, give rise to the development of ketones through the carnitine shuttle. We know that. But the problem is when there is insulin is present, insulin inhibits both fatty acid breakdown as well as ketone production. So that is why two parameters we look for: glucose, low ketones, and low fatty acids. So that is consistent with the diagnosis even if insulin is absent. Because
you get the lab results quickly?
We get it within 1 hour.
Even free fatty acid, okay.
That is welcome.
And have you looked at the data that you showed about ketones persistingly low versus rising? Have you compared in your experience how you can predict the persistent hyperinsulinism versus transient? The study you presented that if ketone...
It's only the study published, but we haven't tried it. But ketones, we do it only in the critical blood samples when the glucose infusion rate is more than 10 milligram per kg per minute after 48 hours of life, and baby still gets hypoglycemic episodes.
Yes. And regarding the pancreatectomy, your hospital has the expertise, but many centers may not be doing it, so you might have to refer out, right? And 4 grams is so minuscule. Is it like a thin spread out five? It's almost like a fibrous layer, is it? Pancreas.
Yeah, but laparoscopic excision, we are doing all laparoscopically now. We don't do open. We've got expertise, about 6 to 7 surgeons we have available.
Is there anything to guide them intraoperatively?
No, nothing. It is only their scope
Anatomy and the visualizing.
And we have a frozen section. We'll do frozen section in the theater itself. Every part, they start from the, see, when you're doing a diffuse disease, for a diffuse disease, when you're doing a neonatal pancreatectomy, we start from the tail end of the pancreas. We take the tail end, we keep on doing sections, continue to do it, and confirm that there is evidence of hyperinsulinism. So that is how it takes about operation goes for about 6 hours minimum.
So yeah, very meticulous. I think you presented, most of your citations were from your own studies. So amazing work, and you're going as an international expert to multiple international conferences representing this topic. So, it is lucky that you're able to speak to us on this niche topic, which is your area of interest. Thank you so much, Dr. Suresh. And in terms of the message regarding your first lecture on hypoglycemia as well. I know all of you are doing the protocol-based approach, but feed-centric approach is going to be better to reduce the admission. So any final messages on how to change from glucose-centric to feed-centric if a unit is not following that?
No, glucose-centric means we are concentrating on glucose levels. The moment the baby is born, because it's a diabetic mother's baby, you do a glucose level. That doesn't tell you anything because you cut off by clamping the cord, you stop the glucose supply. Plus, you didn't tell the beta cell that the baby is going to be born and the beta cell continues to secrete some amount of glucose. So that leads to a low dip in the glucose that comes to a nadir of 1.5 or 1.1 millimoles per later. That is goes to everybody will go through that. But during this period, I always say God has given you time for dry the baby and put the baby onto the mother's chest. Skin to skin care has shown to stabilize 4 things. One is temperature, heart rate, respiratory rate, and glucose. This is there in the Cochrane data is there. So it says these 4 parameters can be, and we are finding the effect of that. And the nurses, we are trained for that. We have got about half a dozen nurses only does this. And they are standing there for, because we've got 12,000 deliveries in our hospital. And our 70% is high-risk deliveries of Singapore. We are the tertiary center for complex deliveries and high-risk deliveries.
The effect is irrespective of the mother not having much milk at the start, even if it's a primary.
Doesn't matter. We allow them to suck, but the baby lose interest probably because of no milk. Baby becomes lethargic or something like that. Take out the baby and send to the. We have got nursery for every postnatal wards. So the nursery people will feed. If we have parents already consented, we'll use bank milk. Otherwise, we'll use formula milk.
Is there any antenatal expression in your unit, like the mother start?
No, don't do that.
Okay, that's fine. Before you close, any comments or thoughts on any advice to the developing world, how people can be cautious? I think the postnatal support you have is amazing, but in India, the monitoring and things may be not as good it should be. So to err on the side of caution, many people may end up giving formula, but it may do long-term harm in terms of establishing breastfeeding. So I think the quality improvement project should look at how you can improve your support in the postnat. Is that do you agree with that approach?
I agree with that. See, always we tell no mothers, we give a counseling saying that give formula milk.
Yes.
We tell them put to breast, allow the baby to breastfeed, and after that baby still feels hungry or baby is asking for feed more frequently, you just top up, but using the cup, Pellada or the cup, whatever you use it in India and all typically. But remember, looking for signs, early signs of hypoglycemia,
Yes.
like lethargy, poor activity, excessive cry or poor cry. These are early, very simple signs mothers can pick up. And the baby's hunger at the same time. And the baby's okay. Mummies can monitor very well at home by looking at the number of times the baby passed stool and urine. I always sing this song to the mothers that remember, if you tell me over the phone that you're changing the pampers 6 to 8 times, I don't have to ask you whether you're feeding very well or not. On 3rd or 4th or 5th day, the stool is changing already to yellow. We know that you're feeding very well.
Yes.
We're still passing only green stool, then we know that we're not feeding well. And so these are all the simple tips we can give. I made that leaflet, which is very useful actually. The mothers will take it in the phone. And I find those who read that one, we can see that they come back with a excessive weight gain. Excessive weight gain in SGA babies.
Overfeeding.
Overfeed. And what we do also for all SGA babies is we do ASQ, ages and stages questionnaire. At all babies who had hypoglycemia, we are doing ages and stages questionnaire, which is starting at 3 months, 6 months, 9 months, 12 months, 18 months, and 24 months.
Developmental monitoring tool.
Developmental. So that this is assessed by them in addition to our own assessment.
Yeah.
So a double level.
Precaution if I miss out on one side.
So we pick up speech delay is the commonest problem we find. In my cohort, speech delay is the number one, but majority of them will recover by about little delayed. Like we refer about 15 to 18 months.
Even if they are not symptomatic?
They are not symptomatic. We refer them 15 to 18 months. We refer to the speech therapist.
And have you seen any long-term effects of using disoxide? I mean, because you said the brain and the gut both have the potassium ATP channel.
No, we cannot split the hair because disoxide use is very limited now.
You can't have numbers to demonstrate.
The genetic forms is very less for us because genetic is only 1 in 30,000. So that comes only, but last year we had 3 cases. So that we cannot say that, but it is probably is missed in the community. Other hospitals, and whether we don't know whether the private sectors are doing it properly, we don't know. They're missing or they may be going out of the country, we don't know. And deaths, we don't know the cause for it. Like that. So we can't tell exactly the incidence of genetic forms of hyperinsulinism because we got a floating population. Even though Chinese, Indian, and Malay are the main population of Singapore, we are finding this paternally inherited form of heterozygous fathers, the paternally inherited form of ABCC8 mutation, more common in Singapore. You know something, our gastro data, that is a growing up in Singapore, we have got a data which is very, very good data and a large number, and the data shows 1 in 780 fathers are carrying this heterozygous state for ABCC8 mutation. But they are not manifesting. That's what we need to assume.
Yeah.
Our last 2 patients, both the baby's fathers don't have any manifestation.
Yeah.
But their other children also don't have. One father has got 3 more children from another wife, and this second wife, first child is manifesting. The other one, the father is from Tamil Nadu, mother is Tamilian but born and brought up in Singapore, no relationship at all. And you find paternally inherited with maternal deletion. And the baby was, something, the mother is a small mother, previous 2 children normal size, this baby came out as 5.2 kilos. So that means endogenous hyperinsulinism is already documented.
Yeah.
We had to take out 95% pancreas and the baby is fine now.
Interesting. In terms of risk factors, you didn't mention labetalol or maternal beta blockers. I mean, I think most of these would come under the SGA, but
transitional.
yeah. So you don't monitor that group of babies specifically.
We will, because if they are all babies who are mothers are getting labetalol, we will monitor them.
So that's on your list as well.
That's another.
I think one message for everyone watching is that if a mother is diabetic and you can consider supporting their breastfeeding simultaneously, if you do need formula for the low sugar, make sure they understand it's temporary and not to fail in the breastfeeding part because they get anxious, and obviously make sure the support is maintained when they go home as well. So thank you, Professor Suresh. I mean, it was amazing, and thank you for your patience as well for completing the 2 lectures. Appreciate your participation as well. Thank you so much.
Thank you, Sridhar, for hosting this meeting.